It's a great pleasure to spar with my friend Sven Scooby on this subject. Now, I've mentioned there that I'm Vice President of the National Osteoporosis Society. Now, this does not mean to say that my colleagues, who are mostly physicians, agree with me. I mean, we must make that quite clear. This is my own personal view, and of course I'm right. Now, do we have a role in the treatment of osteoporosis? No, who else? No, who else is going to treat women correctly with their osteoporosis? I firmly believe that estrogen should be the first choice therapy for prevention and treatment of osteoporosis in women under the age of 60. Another famous Dane, Klaus Christensen, has made the point to me that he thinks it should be first choice, second choice, and third choice for the treatment of osteoporosis. And I do agree with him. Now, which patients should we treat with estrogens as first choice? Menopause, of course. Premature menopause, no question about that. Hysterectomy and BSO in younger premenopausal women. Anorexia, eating disorders. And these thin women, these healthy, and you all know them, healthy, thin women who exercise in the gym and they walk their dog for 2 hours a day and they think they're doing exercise and protecting their bones, but they're thin, and that's why they get osteopenia or worse. These 5 groups of women are really so obvious to be treated with estrogens, and yet my colleagues in the Osteoporosis Society, physicians, would hardly think of treating these. They'd be given bisphosphonates and strontium and all sorts of stuff which Mark Brinkout this morning quite rightly said were bone poisons. I mean, I don't know why we do it. And I stand up at these osteoporosis meetings and I say, these anorectic women aged 30 with lousy bones, why do you give them bisphosphonates? And they say, yes, I agree, we shouldn't, but they still do. They still do. So that's a problem. And it's very hard to understand why bone physicians and rheumatologists rarely use estrogens. Now, Sven's different, that most of them are frightened of estrogens. Sven is a hybrid. He's a hybrid of a hermaphrodite, if you like. He's a hermaphrodite. He's half physician, half gynecologist. And he knows very well that the best treatment for these women should be estrogens. But there is this anxiety about hormones based upon this 2002 rubbish from WHO. And some of the side effects are quite unjustified, like this one. Normally get some laughter, that slide, but no matter. You're a polite audience. Now, the advice from the regulatory authorities was that we use the lowest dose, shortest time, not first-line therapy for osteoporosis, are not indicated for coronary heart disease. We now know, I think, that all of those points are wrong, yet they have not been changed by the regulatory authorities. Lowest dose, you must have a dose that works. And the dose may be different for hot flushes or vaginal dryness or osteoporosis or depression. You need a dose that works. For the shortest time, they need it for a long time until the symptoms have gone, until they no longer need a vagina for intercourse or bones or whatever. They keep it up for some time. And not first-line therapy. I mean, that is surely wrong, and it will change sometime with the new data. And we now know from this new Danish study about the long-term 10-year follow-up in the BMJ last week, that estrogens do, in fact, present coronary heart disease. And I want to make a point now that, that HRT has been bedeviled in the last 10 years by bad American epidemiology, bad British epidemiology, and the one sort of beacon of sanity comes from Denmark. From Christensen and this study of 2 weeks ago, from the name I can't pronounce, but you know who she is. And now by 2012, all these side effects have been retracted even by the WHI people. Yes, Sherbeg, this is the study here. After 10 years of follow-up, women receiving HRT early after menopause had a significantly reduced risk of death, heart attacks or heart failure, without any apparent increase in breast cancer or strokes. Now, it has gone, the physicians have rejected estrogens in such a comprehensive way that here is a case. A 45-year-old woman, postmenopausal, with hot flushes, night sweats, depression, loss of libido, and low bone density. Now, what is she given? Now, most in this room would give estrogens. It makes a lot of sense. But not physicians. Physicians would use anything but use estrogen. So I have invented this new nightmare drug called Profox. This new nightmare drug of Prozac and Fosamax. So she'll have Prozac for her depression, she'll have Fosamax for her bones, she'll even have antidepressants for her hot flushes. Are we so stupid that we accept that? And as for loss of libido and dry vagina, well, she's 45, far too old for that. So that is a physician's view of things. So this wretched woman will be given Profox. There we are. The ideal treatment for low bone density is transdermal estrogens. And I was very pleased to hear the view that transdermal is probably safer than oral, patch or progestogen. But physicians don't want to deal with minor estrogen effects. They don't want to deal with breast discomfort and bleeding. They don't want to do a vaginal examination under any circumstance. Most physicians wouldn't recognize a vagina if they fell into one. So anyway, that's the problem that women face. This is one of Mark's slides showing the importance of estrogen, skin thickness, cerebral changes, cardiovascular, and cartilage. I cannot get my colleagues, my physician colleagues, to understand or to accept that estrogens help preserve the intervertebral disc that makes up 20% of the spinal column height, a shock absorber. Now here's the Mark's data here showing that there's a menopausal spot in the middle, menstruating women after that, and HRT on the extreme right there. And you can see the second one, bisphosphonate, the effect of bisphosphonate on the cartilage, zippo, nothing. So, and this is a study of ours in older women, 6 years of HRT, showing the increase in collagen. This is bone biopsy. Collagen in cortical cancellous bone, 6%, 25%, and the increase in bone density, 28% in the proximal femur and 14%. These are older women with osteoporosis. It's a study of 20 years old that would not be allowed these days, but there we are. So we've got to ask ourselves, are bisphosphonates, SERM, strontium more effective than estrogens? No, they're not. Any effect on collagen, the skin and disc? No. Safer? I doubt it. And are they associated with other benefits, better well-being, better sexuality, heart attacks, etc.? Estrogens as effective or more effective than other treatments, etc. Fewer heart attacks, protect the discs, safe and cheap. Now, final slide here. I mean, what do we do? What do we as gynecologists who believe in this and the data support us? How do we educate bone physicians? We've got to try very hard to discuss HRT at osteoporosis conferences. You know, although I'm vice president of this setup, I cannot persuade my colleagues to have a lecture on HRT at this international world conference every week because they're not interested. Persuade advisory bodies to consider their evidence, revise their views, or just give up, and that physicians are a busted flush and you will not persuade them to make this sensible choice. So I would suggest that if we're having a vote, and I'm sure we're not, is that you support the motion that estrogens, the gynecologists have a role in treating osteoporosis.
Thank you.